Great. Thank you so much. Can you guys see my screen okay?
Yes.
Okay, perfect. It's a great honor to be here. As Dr. Chiuri said, this is a great effort that you guys are doing, and having personally trained in India and having been in this situation multiple times where bringing simple things like palliative care that we take granted for in the United States to people in developing countries, I think it's a great effort, and I'm really thankful for the foundation for giving me this opportunity. So I'm going to talk a little bit about the updates we have in the second and later lines of management for kidney cancer. I do not have any disclosures, and I have a couple of questions which I think we are going to come to at the end of this talk. So I'm going to skip these slides. So the main objectives of my talk today are, one, to recognize treatment options in the second line and beyond management of metastatic kidney cancer. I'll try to summarize as much data as possible. There's a lot out there, some retrospective data, some prospective studies coming in. So if I miss anything, bear with me. It's a 20-minute talk. I can hopefully do justice to all the work that some of the people who are here in this meeting have done in this realm. And then I'll also review some data on upcoming drugs and what to expect in the second line management within the next few years. So Dr. Chiuri very nicely summarized, frontline treatment options for kidney cancer, and I don't need to go through all of these options. So I'm going to move on to what I call as different eras in how we've progressed in the management of kidney cancer. So when I started my fellowship in 2015-16, the treatment algorithm for kidney cancer was very simple. Patients would get TKI. If they fail, they would go to another TKI, or they would go to an mTOR inhibitor, or you would enroll them on a clinical trial. But as I graduated my fellowship, this is how the paradigm shifted. So between 2015 and 2019, there have been multiple checkpoint inhibitor drugs that got approved. There's cabozantinib, then there's the combination of lenvatinib with mTOR inhibitor, everolimus, and then all the drugs that Dr. Chiuri mentioned in his talk. And then in 2020, even between, like he said, when we submitted our slides to now, there are new results and new FDA approvals that have emerged with the Nivo-Cabo FDA approval. And then there are new drugs in the pipeline, like the HIF2 alpha inhibitors. So it's really exciting to be part of the team of doctors who manages kidney cancer patients. But then this also comes with the challenge of how do you sequence these approved agents. So having had a very simple algorithm in the past to now having all these different agents that are available in this setting makes it very complicated as to what patient I'm going to choose. There are no approved biomarkers, and we have all these treatment options that are available. And then also always want to stress the importance of, if available, enroll patients on clinical trials. But IO combination with TKI, or combining IO, or giving a single agent IO, or do you want to give a VEGF TKI if somebody got an IO combination in the frontline setting? These are all the answers we are trying to answer from some studies that have been done and are hopefully going to be done in the future. So this is just a summary of second line treatment options. There are clinical trials available for many patients in the advanced setting, but if not clinical trials, we have several standard of care options that we can now pick from. These are either immune therapy based regimens, these could be targeted therapies, or these could be other agents that could be used in selected circumstances for management of these patients. So sequencing, as most of these drugs, especially the IO combination like axi-pembro, axi-avelumab, cabo-nivo, and cabozantinib, and this is just a brief summary slide of what options we can use in the frontline setting. As these get used up in the frontline setting and we move on to the second line and advanced setting, it is a little bit of a conundrum as to what options do we use in the next line setting if you've already exhausted some of your bigger players, if you will, in the frontline setting. But then also, as everybody knows, you want to use your best drugs in the frontline setting because many patients will not have a second chance probably to get treated. So most of these slides just represent how complicated that decision is becoming now, as most of these agents are getting used in the frontline setting. So these are some of the pivotal trials. Just a breakdown. This is in the post-TKI era. Some of the older trials that that brought some of these drugs, the TKIs and the mTOR inhibitors, in the second line and beyond setting. So everolimus, axitinib, cabozantinib, and nivolumab were tested. For example, everolimus in the RECORD-1 study, axitinib in the AXIS study, and the METEOR study, which looked at cabozantinib comparing it to everolimus. And then there was the Checkmate 025, which basically brought nivolumab into the forefront when it was compared with everolimus. And as you can see, we have definitely advanced from where everolimus led to an overall response rate of 2 months. It was compared against placebo, to when Checkmate 025 came about, the overall response rate was 25% as compared to 5% with everolimus alone. Similarly, we've made progress in terms of improving median overall survival. Of course, we are not making cross-trial comparisons, but just looking at these trials, it shows that everolimus versus placebo improved median overall survival from 14 months when treated with placebo to 14.8 months. And then axitinib improved overall survival to 20 months as compared to 19 months with sorafenib. Cabozantinib was 21 months versus 17 months, and nivolumab was 25 months versus 19 months with everolimus. And then another important study was the phase 2 study. Lenvatinib and everolimus was compared with everolimus alone, and here the overall response rate improved from 3% to 43%. And this is it's an effective drug combination. And as Dr. Chiuri presented, this lenvatinib combinations with pembrolizumab and other drugs are now moving into the frontline setting. So hopefully we'll see more data in this regard in the frontline setting also. So what is the data? Like, as I said, if patients have received checkpoint inhibitors in the frontline setting, what do you do in the second line setting? So what is the data? And some of the data I'm going to highlight. So what about tyrosine kinase inhibitors? So this was an interesting study, which was a single arm phase 2 trial led by Ornstein et al., who basically they studied patients with metastatic RCC, patients who had progressed on or had been intolerant to checkpoint inhibitor therapies, and axitinib was given in individualized titrated doses. So the starting dose was 5 milligrams BID, and then based on how well they tolerated it, they were slowly titrated up to a maximum dose of 10 milligrams twice daily. The study had a total of 38 patients. The study did not itself meet the pre-specified threshold for an improvement in progression-free survival. But as you can see, the overall response rate was about 45%, and the progression-free survival was about 8.8 months. So this study does stress that there is a role for using TKIs in patients who have progressed on immune checkpoint inhibitors in the frontline setting. For example, IO combinations or simple single agent IO agents that might have been used. And this is another study. So the lenvatinib everolimus study that I mentioned, the phase 2 trial, which had randomized in a 1:1 manner patients to receive lenvatinib with everolimus versus single agent lenvatinib or single agent everolimus. They noticed when the study was reported that almost 89% patients in the combination arm had experienced some form of dose interruption, and treatment discontinuation rates were pretty high. Almost 30% patients had to stop the combination. So it's not an easy treatment to tolerate. So in an aim to individualize lenvatinib dose and to see whether we can in fact use a lower dose of lenvatinib, this small phase 2 study was reported recently by Dr. Pal at the IKCS meeting. And they found that the primary efficacy endpoint of non-inferiority with the 14 milligram dose for objective response rate at week 24 was not met. The primary safety endpoint, however, as they said, as you can see here, the grade 2 or greater than 3 treatment-related adverse events are also pretty comparable between the two arms. The median duration of treatment was 7 months in the 14 milligram dose, and 18 milligrams dose. People were able to stay on this treatment for about 8 months. So overall, they didn't really see, and based on this study, 14 milligrams is actually not a dose we can recommend to our patients. 18 milligrams still seems to be better in terms of an overall response rate. And the trend, they also saw a trend towards better progression-free survival and overall survival in the 18 milligram arm. So we are not able to recommend a lower dose of lenvatinib at this point. And then there are also other studies which have looked at supporting the use of targeted therapy after immune checkpoint inhibitors. So this is one study where 314 patients were included. It's a retrospective study. Around 87.9% of these patients were treated with a VEGF RTKI in the second line setting, and the remaining patients, about 38 or 12% of these patients were treated with mTOR inhibitors. And as you can see, this data also supports that targeted therapy does have clinical activity after patients have received checkpoint inhibitors in the frontline setting. The patients who received the VEGF RTKIs versus mTOR inhibitors tended to have better clinical outcomes in terms of overall survival probability. So these findings may help inform treatment guidelines. Maybe it is preferable to use a TKI after IO failure rather than go to an mTOR inhibitor. So as you can see, the time to treatment discontinuation with a VEGF RTKI after receiving IO therapy was about 6 months versus about 2.8 months in the mTOR inhibitor arm. The 1-year overall survival probability was also better for the patients who received TKIs. Then there was another retrospective study which was conducted by Dr. McGregor's group, Dr. Chiuri's group at Dana-Farber. They looked at 86 patients who had, in the frontline, received checkpoint inhibitors in either alone or in combination with VEGF TKIs or in other combinations, and they found that overall response rate with cabozantinib after IO failure was almost 36%, and the median time to treatment failure used as a surrogate for progression-free survival was about 6.5 months, giving us more additional data that cabozantinib is indeed active in patients who've been treated with previous IO-based therapy, and they didn't notice any new safety signals either. And then another small study which looked at patients, about 33 patients who had received either a first-generation TKI or a second-generation TKI, Axi-Cabo, in the post-Nivo-Ipi setting. So these were the patients who had received the dual checkpoint inhibitors in the frontline setting. And again, they found that progression-free survival was significantly longer in patients with a long first-line duration of response for obvious reasons, because they probably had a better biology. But then this also laid grounds to suggest, based on the median progression-free survival, that there is a sustained benefit of using TKIs in the second-line setting, even after the Nivo-Ipi combination. And then I want to say a couple of words about tivozanib, which was tested in a phase 3 study, TiVo-3, which included 350 patients who were randomly assigned to receive either tivozanib or sorafenib. So this drug was used in the third or fourth line setting. And as you can see from this Kaplan-Meier curve, it seems like this is an overall survival curve, and they didn't see any benefit of using tivozanib over sorafenib. However, there was a smaller subset analysis, if you will, which was presented by Dr. Chiuri at ASCO this year. And if you look specifically at that group of patients who had received checkpoint inhibitors in the frontline setting, they did seem to benefit from tivozanib in the advanced line setting, and the hazard ratio for post-IO treatment was almost 0.55. So given the anti-tumor activity, the tolerability, the adverse event profile was comparable between the two arms, tivozanib may still be a useful addition in the armamentarium of treatment options when you're at that third, fourth line setting and patients have received IO therapy in the past. Then the other question that always comes to our mind, like, is there any safety and efficacy data for immune therapy re-challenge? And unfortunately, there is no prospective data yet. but we have this data which was presented again. It was published this year or last year in 2020, which looked at evaluation and safety of an immune therapy re-challenge in patients with kidney cancer. It's a small retrospective study of 69 patients. And as you can see in the overall response rate in patients who receive single agent immune checkpoint inhibitor is about 30%. And so this does suggest that IC refractoriness to immune checkpoint inhibitors could potentially be overcome by introducing a checkpoint inhibitor in the later lines of treatment. Maybe because the intervening therapies, if you use some TKI or if you use some other agents in the intervening time period, maybe they act on the microenvironment and then sensitize the tumors to further treatment with checkpoint inhibitor is one of the proposed hypotheses that was a conclusion from this study. But it's definitely an interesting finding, and we probably need more prospective clinical trial data in this setting, but it's definitely of interest. And then the next question is, if you've used a dual checkpoint inhibitor, if you've used in the frontline setting nivo-ipi after you've used axi-pembro in the frontline setting, is there any data to use the dual checkpoint inhibition with nivo-ipi in the second line setting? And this again comes from two different studies. One is a retrospective study which was presented by Gul was actually published by Gul's group from Cleveland Clinic and JCO, and then Dr. Chiuri presented a prospective data from the fraction RCC study, and both the studies have a comparable number of patients, and at a median follow-up of about 12 months in the first study, they found an overall response rate of about 20% and progression-free survival was 4 months. Similarly, in the fraction RCC study, the overall response rate was about 15%. None of these studies showed any complete responses. So these studies do support the use of salvage ipi-nivo in patients who've received a TKI-IO combination in the frontline setting, but always, we have to always think about the data that we saw in the frontline setting with ipi-nivo, where the overall response rates were much higher, almost to the tune of 40%, and we even saw some patients, about 11% patients, who had a complete response with ipi-nivo in the frontline setting. Progression-free survivals were much longer. So it is active definitely as a salvage regimen, but it's not as active if you use it in the frontline setting. So again, I'm going to skip this because we'll go over questions in our question and answer session. But this is an interesting question, which investigators were very excited to use this approach because, as we all know, people who treat patients with kidney cancer with the dual checkpoint inhibition, ipi-nivo, we are often fraught with a lot of side effects that we have to deal with. So is there an option that you start patients with nivolumab alone, and then based on their response, based on how they are doing, add salvage ipilimumab? So this exact approach was studied in these 3 clinical trials. Some of them presented at ASCO this year, and the HCRN, GU16260, and Omnivore, and then the Titan RCC, which was presented at ESMO in 2019. And basically, as you can see here, the overall response rate was very poor, with 12%, 13%, 4% response rate in the 3 trials respectively. And we didn't really see any complete responses when you added ipilimumab to a patient who was already getting nivolumab. So at this time, I don't think we can recommend treatment with single agent nivolumab followed by salvage treatment with the combination of nivo and ipi. It has shown limited efficacy, and it's not something we can recommend to patients in clinic. And then there's interesting data that was presented by Lee et al. At ASCO 2020, where they tested whether we can use a combination of lenvatinib and pembrolizumab for patients who had progressed on frontline checkpoint inhibitor therapy. And as you can see, it's a 104 patient study. Patients had received PD-1, PD-L1 inhibitors in different combinations, either alone or in combination with ipi-nivo as a combination, or in combination with VEGF therapies. And this is a waterfall plot that was presented at the meeting, and they showed that the overall response rate was in the range of about 55% by investigator assessment. So another study, which is called Contact 3, is currently ongoing, which is testing atezo and cabo versus cabo zantinib alone in the third and fourth line and beyond setting, and hopefully we'll see results from that study soon. So as we move away from checkpoint inhibitors and investigators are thinking of new targets, one of the targets that I would like to mention is the glutaminase inhibitor. This figure is actually from one of Dr. Phan's paper, very interesting paper on the role of glutaminase inhibitors in the management of kidney cancer. And as you can see here, telaglenestat was compared in two different studies. One is the telaglenestat with everolimus compared to placebo with everolimus study, which was reported out in ESMO in 2019. And they saw that the combination was well tolerated, and it did prolong, and it did lead to stable disease, not a lot in terms of responses. And then recently, there was a press release from the Cantata trial, which was a trial that had randomized patients to receive. I like to go with CB839. It's just easier to pronounce, in combination with cabozantinib versus placebo with cabozantinib. And unfortunately, they were not able to meet the primary endpoint. So there was a lot of excitement around the glutaminase inhibitors, especially because of the underlying biology and the fact that it does seem to play logical sense in why we should be using glutaminase inhibitors. But this press release that came out very recently didn't show much difference between the two arms. The progression-free survival was very comparable between the two arms. The arms were very well balanced, and about 62% patients had been exposed to PD-1 inhibitors in the past. So I think we are going to have to move forward to other clinical trials. For example, this is a very interesting study which is being conducted through Alliance. Dr. Tian Zhang and Dr. Chiuri are leading the study through Alliance. It's the pedigree study. It's an adaptive trial where patients get ipi-nivo in the frontline setting. Patients have to be intermediate to poor risk category, and then after the induction therapy or after 3 months, they undergo scans, and based on the results of the scan, if they have a complete response, they are continued on nivolumab alone. If they have progressive disease, then you add the cabozantinib. And if they are in the middle, then they are randomized either to continue just nivolumab, or you can add cabozantinib at this. So this trial will, I think, help sort out the question about sequencing of therapies. It's a trial that I encourage patients to participate in at my institution as well. And then a word on HIF2 alpha inhibitors. Dr. Chiuri's group has played a very big role in bringing these drugs to the forefront, and I think we'll hear a lot more about these drugs in the near future. So this PT2385, which was the initial HIF2 alpha inhibitor drug, was presented in the form of a phase 1 dose escalation trial where they saw response rate to the tune of 13%. And eventually the results from a phase 2 study were presented, and there is an ongoing phase 3 study now, which the molecule is MK6482. It's just a more advanced molecule based on the bioavailability and pharmacokinetic properties, which targets the HIF2 alpha inhibitor pathway. And patients that are enrolled on this study, the MK6482 versus everolimus study, have failed up to 3 treatment options in the previous setting. So it's going to be hopefully reported out soon. And then these are the other ongoing trials which are looking at the HIF2 alpha inhibitors, some in the phase 1 setting and some in the phase 2, phase 3 setting, also in combination with different drugs or alone. And then just one slide on this other novel molecule, which is currently being studied. This is the NKTR or BEMPEG. I'm just going to call it BEMPEG. It is designed to provide sustained signaling through the heterodimeric interleukin-2 beta gamma receptor pathway. And this through this pathway, it drives the proliferation and activation of CD8 positive and NK cells. And since it has limited binding to the interleukin-2 alpha receptor subunit, it's supposed to prevent unwanted expansion of Tregs in the tumor microenvironment and hopefully make the drug more effective and cause less toxic adverse events as compared to the standard interleukin-2 that we use. So it has. There have been some reports that we've seen at ASCO in the frontline setting as well as in the second line setting in combination with nivolumab, and there is an ongoing trial looking at this drug in the frontline setting in combination with nivolumab as well. So the future holds a lot of treatment options. I was running out of time, so there's, I mean, I can't cover everything. Hopefully, as we have more of these meetings, we can keep expanding the data that gets presented at meetings. But there's a lot of hope in that we have like novel human endogenous retrovirus autologous T cells. Then we have some other targeted agents which are aiming to target the metabolic pathways like the IDO inhibitors, and then some other small molecules which look at the CD39, CD73 adenosine pathway. So there's definitely more to come as we develop new drugs through basic research. We enroll patients through clinical trials. We do clinical research, and then we conduct computational analysis. Hopefully, more drugs are going to continue to evolve. The best treatment option in the second line right now, as where we stand, is heavily dependent on what regimen we've used in the frontline setting. And many of these drugs, you want, like Dr. Churi said, hopefully we'll have a triplet regimen, which is going to be soon studied and maybe available for patients in the. So if we exhaust all our big the TKIs and the IO checkpoint inhibitors in the frontline setting, we definitely need to open up more options and start thinking about next steps for these patients. So there are other considerations, however, that you have to include in your decision making. You have to look at patient comorbidities. What's the efficacy data? Are these drugs even available? Because many of these drugs might not be available in some of the smaller places or other countries. And then physician and patient preference, lengthy discussion with the patient and talking to them about all the side effects and what they want. Quality of life is always very important. And then always stress upon availability of clinical trials. If there's any option for patients to enroll on trials, that's extremely important, because that's the only way we can bring new drugs to our patients. So with that, I thank you for this opportunity, Binaytara organization, and I'm